So hello and welcome back. Today I'll be talking about part 2.2 in an approach to vomiting and abdominal pain, and we'll be discussing specifically intestinal obstruction and or other pseudo obstruction. Additionally, we'll also be talking about mesenteric ischemia as a cause of presentation very similar to intestinal pseudo obstruction and intestinal obstruction. So the structured learning objectives for this video would be we will try to compare and contrast between the three types of intestinal hypomotility syndromes. As I just mentioned, that would mean we'll talk about acute mesenteric ischemia, true intestinal obstruction, and intestinal pseudo obstruction. True because there is something called intestinal pseudo obstruction. Now, then we'll try to deduce the causes of acute mesenteric ischemia, and along the way, we'll also become aware of the base rates of each of these causes so as to be able to predict clinically what the likelihood of a particular cause is. Then we'll try to deduce the causes of true intestinal obstruction with an emphasis on quote unquote non-surgical causes. We'll try to deduce the causes of intestinal pseudo obstruction using its mechanisms. This could be due to systemic disorders, or this could be due to an alteration in neural input to the intestines. And finally, it could be due to an decreased response of the intestine to otherwise normal neural input. So, getting right into it, the first step will be to differentiate between these three entities, that is acute mesenteric ischemia, true intestinal obstruction, and intestinal pseudo obstruction. Now, why I approach this in this way is because of something very simple actually. Vasculitic acute mesenteric ischemia, especially in patients with the SLE, often gets confused with pseudo obstruction in SLE due to intestinal pseudo obstruction in SLE. So this is a clinical scenario that often arises in rheumatology and internal medicine generally, and therefore detailed evaluation of the history is always warranted. And as we'll see, the history makes things very clear, and makes it very clear as to what may be the cause and what exactly how the imaging needs to be evaluated, and we'll be talking about the imaging in the next coming session. So, as always, I'll be here comparing these disorders head to head. We'll talk about the pathomechanisms. So, first, acute mesenteric ischemia, as the name would suggest, is due to decreased arterial blood flow to the intestinal wall. Now, venous obstruction can also technically cause acute mesenteric ischemia, but I'm restricting myself right now to acute mesenteric ischemia because we'll be talking about hepatic venous outflow obstruction, and in that context, mesenteric venous obstruction, splenic vein obstruction, and renal vein obstruction in 2 videos from now. So I'll be restricting the talk to that because the evaluation is very different. Now, true intestinal obstruction is refers to mechanical obstruction of the to the movement of the GI luminal contents. This could be either due to an extrinsic compression from outside the wall. It could be due to a thickening of the wall that is causing compromise of the lumen within the gastrointestinal tract, or it could be a actual mechanical obstruction within the wall of the gastrointestinal tract. So again, just to reiterate, it could be something is compressing it from outside. It could be that the wall has become too thick and therefore is compromising the lumen. Alternatively, there might be something actually sitting within the wall obstructing the the movement of contents through the gastrointestinal lumen. Now, pseudo obstruction is when none of these three things is there. However, gastric wall motility has decreased. And as I just said, that may be due to systemic causes. It may be due to neurological input being to the gastrointestinal tract being altered, and it may be due to GI wall disorders, primary disorders that decrease the response of the gastrointestinal tract to the neural input that it is receiving from the parasympathetic innervation that it has. Now, gastric motility, as would be expected in case of acute mesenteric ischemia, because as is obvious, the ATPs or energy is required for both muscle contraction and relaxation, and also initial mesenteric ischemia causes activation of sensory with special visceral efferents within the wall of the intestine. So that causes reflex spasm of the malperfused GI wall, and that can initially result in hypermotility. That is an increase in GI motility, but as the mesenteric ischemia persists, that increase in GI motility always, as a rule, progresses to decreased motility. Similarly, in intestinal obstruction, once, say, a mechanical obstruction has occluded the wall of the intestine, the parts of the intestine that are proximal to that occlusion, say this is proximal and this is distal. So the parts that are proximal to the intestine, they contract vigorously in order to increase the pressure here so as to push the occluding object distally, and as a result get rid of the obstruction. So in both cases, there is a initial hypermotility which is followed by a progressive decreased motility. However, intestinal pseudo obstruction, the primary problem is decreased motility. So there is always a progressive reduction in gastrointestinal motility. So let's see what that translates into clinically. So when we talk about the clinical presentation, because of this initial increase in motility followed by decrease in motility, the presentations vary. So in case of acute mesenteric ischemia as well as in true intestinal obstruction, initially you get an increase in GI motility, which can manifest as one of three things. It could be vomiting due to reverse peristalsis. It could be diarrhea, but it's not really diarrhea. It's just like there's just an increased, frequency of passage of feces, and that may manifest as an increased number of passes of feces in one day, or it may be due to may manifest as an fecal incontinence on the part of the patient. Now, this is associated at that time with a colicky abdominal pain. This is because as the bowel lumen goes into spasm, obviously the pressure inside the wall of the intestinal of the viscera of the wall of the intestine, that increases. So say there's an obstruction here, and the intestine here is contracting vigorously. So at that point of time, there is further compromise of the blood supply to that intestine, and that causes a sudden pain, which which increases because of the increased oxygen demand that is there within the wall of the intestine. That sudden pain is very acute in onset, lasts for some time, and then resolves as the bowels subsequently develop hypomotility. So now, importantly, this abdominal pain is focal and or localized more than diffuse. Now, this is something that is very important because focal and or localized is something that is the primary presentation with which this the patient presents to us, and diffuse is an uncommon presentation of such things. So often the patient is able to localize the pain to either periumbilical or the inferior abdomen, although it is poorly localized. Okay, so it's often not well localized. It's significant, but not very well localized. But it may be focal and very well localized also. Okay. Now, subsequently, as the ischemia progresses or as the intestinal obstruction is not relieved, and because of that, there is progressive ischemia to the proximal bowel as the vigorously contracting intestines obviously have increased pressures within the wall. You develop a progressive decrease in intestinal motility, and this is then associated with a more diffuse and for a rather poorly localized form of abdominal pain. So this progression is rather characteristic of either an intestinal acute mesenteric ischemia, or it is characteristic of an intestinal obstruction. And per se, these two cannot be differentiated just based on this history. Now, in case of pseudo obstruction, and this is very important because in SLE related to intestinal pseudo obstruction, if you have a history of increased GI motility, then it's not intestinal pseudo obstruction. Okay, it is the patient has had mesenteric ischemia or has proper obstruction. So, patients with intestinal pseudo obstruction, they develop a progressive constipation. That is, a decrease in GI motility results in a decrease in the passage of stool. So they pass stool less than or equal to once in 3 days, and along with that, there is a significant diffuse abdominal pain, primarily because of gastrointestinal distension and bloating, and that is what the patient presents to us with. Now, if these conditions are not relieved, this develops into complications. Now, obstipation refers to a clinical condition in which you are not able to pass even flatulence. That is, you are not able to pass gas, in addition to not being able to pass stool. Now, in case of acute mesenteric ischemia and in case of intestinal obstruction, as the severity of the disease increases, the gastrointestinal motility is so decreased, it is decreased to such an extent, and in the case of intestinal obstruction, it is the obstruction is so severe that often, as if it is not relieved, the it progresses to proper obstipation. That is, the patient does not even pass feces. Whereas in intestinal pseudo obstruction is very uncommon for the gastrointestinal hypomotility to be severe enough to lead to obstipation. So if it is present, actually, clinically, it is prudent to rule out true intestinal obstruction and acute mesenteric ischemia. Now, as a complication, eventually, if the blood supply to the wall of the intestine is not re-established, then intestinal proliferation is something that is likely to happen. And similarly, if the intestinal obstruction is not adequately released, eventually that part of the intestine becomes gangrenous, and because of that, you end up developing intestinal perforation and secondary release of intestinal luminal contents into the peritoneal cavity, and that obviously can result in peritonitis. Whereas in intestinal pseudo obstruction, uh, perforation is almost unheard of, and the only actual complication that develops is small intestinal bacterial overgrowth, and this happens actually when the disorder is more chronic. Okay, so chronic intestinal pseudo obstruction can result in small intestinal bacterial overgrowth. Those bacteria then ferment, glucose, fructose, other monosaccharides, and as well as to some extent amino acids, resulting in the production of gas, primarily methane, and that gas then distends the gastrointestinal tract, resulting in prominent bloating and flatulence. So again, making obstipation less likely. So as you can see, from the clinical presentation, that is just the history, one can differentiate acute mesenteric ischemia or true intestinal obstruction from intestinal pseudo obstruction. All one has to do is ask, which is often, it's even that is missed in the clinical setting. Okay. Now coming to when you're suspecting acute mesenteric ischemia vis-a-vis obstruction. Now I have not clearly defined how to differentiate between acute mesenteric ischemia and intestinal obstruction clinically because it's very difficult. Okay, you can't essentially. Okay, but imaging can clearly differentiate between the two, and that is what our next discussion will be on. So in that screencast, I'll be discussing in detail how we clinically differentiate between these entities and in what situations does that also become a little difficult. But that is for another day. For now, we'll talk about once we have diagnosed acute mesenteric ischemia as an internal medicine specialist, as a clinical immunologist and rheumatology specialist, what do I evaluate? So in case of acute mesenteric ischemia, the etiology of acute mesenteric ischemia is easily divided into two categories. There is 80 to 85% of cases is due to vascular occlusion. That is, there is an actual obstruction of the lumen of the blood vessel that is going towards the intestinal wall. So this is the intestinal wall, and this is the arterial blood supply to that wall that is actually getting obstructed. So that happens in 80 to 85% cases. In 15 to 20% of the remaining cases, we don't have any obstruction. Okay, that is called a non-occlusive intestinal acute mesenteric ischemia. And in case of occlusive acute mesenteric ischemia, we have a localized hyperperfusion of the GI tract, as I have just said. Whereas in case of non-occlusive, we have a generalized global hypoperfusion, usually due to shock. Okay, and in this situation, as we'll discuss in imaging, there is often adrenal hyperenhancement, and that is something that is very interesting and that we'll come to in our discussion on the imaging of mesenteric ischemia. However, that is present in only around 10 to 15 to 20% of cases, and obviously, in the setting of a patient suspected to have the other causes, usually sepsis is often not a confounding factor. So, shock is often not a confounding factor. So, that is something that this can be ruled out in most clinical scenarios as a possible cause. Now, let's talk about the most common causes, other possible causes, and of these things. So now, see, occlusion of a blood vessel supplying the gastrointestinal tract could be one due to thrombosis. That is, the vessel has got a thrombus that is formed within the vessel. Second thing is there could be embolization. That is, a thrombus was formed somewhere else, either within the heart or within one of the large arteries, and that has dislodged from that area and gone and gotten stuck within one of these blood vessels. Finally, it could be due to actual vessel inflammation, that is vasculitis, and that is when I come into the picture normally. But obviously, I need to know when that is the case and when that is not the case. So I need to know all the differentials. So okay, the most common cause of thrombosis. So so it's almost always occlusive, and 50% of occlusive cases are thrombosis. Okay, so and thrombosis obviously is most commonly caused by atherosclerotic cardiovascular disease, that is atherosclerosis. Okay, so that is the most common overall cause, single cause. Then after that, embolization. Now, by far, cardioembolization, that is embolization from the heart, is far more common. But again, heart, there has to be a reason for embolization from the heart. So the most common cause of that is atrial fibrillation, and atrial fibrillation naturally occurs more commonly in ladies. It occurs more commonly as age increases, and it occurs naturally if you have a parallel pathology or some kind of restrictive cardiomyopathy, as we have discussed in our in the lectures on on cardiac examination, and we'll discuss further in our lectures on restrictive cardiomyopathy. Now, in case of vasculitis, although vasculitis is overall a rare cause, the most common vasculitis to cause GI involvement by far is IgA vasculitis. Now, there is a point to be noted here. IgA vasculitis typically causes venular obstruction. Okay, it doesn't cause arterial or small capillary occlusion. It causes venular obstruction, and therefore the imaging findings are more, akin to those in mesenteric venous obstruction. So there's a lot of edema, and we'll discuss that at a later date. However, the most common overall cause is IgA vasculitis, which on imaging actually can be quite clearly differentiated from the other causes if it is causing venular obstruction. Okay. Now, in case of global hypoperfusion, as is the most common cause of shock, the most common cause of shock causing non-occlusive acute mesenteric ischemia is mixed shock. Then other causes. Now, all other causes I'm going to enumerate as of now. So, the thrombosis can also happen due to large vessel vasculitis, and that obviously could be Takayasu or GCLVV, that is giant cell arteritis, large vessel vasculitis. So that obviously would depend on the age of the patient. If the patient is younger than 40 to 50 years, that is Takayasu, and if the patient is more than 50 to 60 years, that is giant cell arteritis, LV variant. Now, ACVD itself can cause embolization by causing artery to artery embolization. So, say you have ACVD of uh, the aorta, that is a large plaque there and that has gotten disrupted, that can cause embolization into distal vessels, including the mesenteric vessels. Now, in antiphospholipid antibody syndrome, mesenteric ischemia is not actually, it's quite uncommon. Okay. However, it is particularly common in patients who develop a catastrophic APS. So, catastrophic APS is something that one must consider strongly if a patient with APS has started developing intestinal ischemia, and because the course from then on may be precipitously, precipitously go out of hand. So that is something that requires clear differentiation. Now, paroxysmal nocturnal hemoglobinuria is also a cause of thrombosis of mesenteric blood vessels. Again, not a common location. So even in PNH, if it has occurred, there is usually another reason why mesenteric ischemia is the primary presentation. Now, infective endocarditis as a cause of embolization. Now, in case of infective endocarditis, as you can see, embolization is obviously cardioembolic. So there is a vegetation within one of the leaflets of the heart, and that has gotten dislodged and has gone into the mesentery itself. Now, in case of vasculitis, the other possible vasculitides that can cause GI vasculitis are polyarteritis nodosa, ANCA-associated vasculitis, and in patients with long-standing RA and or long-standing SLE, RA and SLE vasculitis, not in just routine patients. Okay. Now, SLE vasculitis, as we'll discuss, is called lupus mesenteric vasculitis, and lupus mesenteric vasculitis needs differentiation from intestinal pseudo obstruction and the intestinal pseudo obstruction loop and the broad umbrella term that is lupus enteritis. So I'll be getting that into the details of that when we discuss lupus. But as of now, pan and ANCA-associated vasculitis are your main differentials in addition to IgA vasculitis, and okay. And notably, PAN would also have pancreatitis in a large proportion of cases, at least 50 to 60%, and that is something that helps differentiate it from ANCA even in seronegative cases. So that's a important clinical point. Now, in case of non-occlusive, the other causes of shock in decreasing order of likelihood, that is septic shock followed by hypovolemic shock followed by cardiogenic shock, are responsible for non-occlusive acute mesenteric ischemia. Now, depending on the cause, the exact vessel affected and where the vessel is affected is also changes. So obviously, thrombosis would occur in the more proximal portions of the blood vessels. So that is why Takayasu, GCA, antiphospholipid antibody syndrome with thrombosis and PNH tend to affect the proximal aspects of the superior mesenteric artery and the inferior mesenteric artery. And importantly, in Takayasu particularly, it is the aorta and therefore the ostium of the vessel that is primarily affected. Now, in case of embolization and vasculitis, because in embolization the embolus can be quite small in size, it can get embolized distally to very small vessels. And vasculitis, depending on the size of the vessel. So, if it's a not a large vessel vasculitis, then the vessels are obviously medium vessel vasculitis or small vessel vasculitis. So, that usually is distal more than proximal. Okay. Now, finally, non-occlusive acute mesenteric ischemia actually affects multiple segments of the GI tract simultaneously, and it actually affects those areas that are at the junction of the watershed areas between the superior mesenteric artery and the inferior mesenteric artery. So, actually, the splenic flexure of the colon is primarily affected. Okay. Now, wall thickening is something that what is important is what segment of bowel is affected. So if a more proximal blood vessel is affected, then a longer segment of the bowel would have been perfused by that vessel, and so that would show thickening. Whereas if a more distal occlusion is there, then a shorter segment of the bowel would have been perfused by that blood vessel, so a shorter segment would be affected. So in case of thrombosis, a long segment is usually affected, resulting in long segment wall thickening. In case of embolization and vasculitis, it is a typically small segment and multiple patchy small segments are affected. And finally, in case of non-occlusive, it is variable, but again, the distribution being that involving the spline flexion of the colon is something that is important. Okay. Coming to quote unquote intestinal obstruction. Now, see, intestinal obstruction, which when it is actual intestinal obstruction, can be due to extrinsic compression. It can be due to some pathology within the wall of the intestine. It could be due to a luminal pathology, as we've just discussed. So, extrinsic compression by far most commonly happens due to adhesions, and for that, usually the patient has had a surgery prior to this, or there is some kind of peritoneal pathology. Uh, Locally expansile space occupying lesions that are either inflammatory or neoplastic in nature involving the peritoneum can therefore cause intestinal obstruction. And there is obviously a special entity called Mirizi syndrome, which is actually a gallstone that is present within the cystic duct. So we have our gallbladder and we have a cystic duct, and the cystic duct obviously combines with the common hepatic duct to form the common biliary duct. Okay, so this is the cystic duct. Now, if there is a stone in the lumen of the cystic duct, that can then secondarily compress can compress the second part of the duodenum, and that can result in intestinal obstruction. So that's a Mirizi syndrome. Anyway, actually, see, it need not. Okay, it's not the second part of the duodenum per se. What ends up happening is that the stone, burrows its way into the second part of the duodenum, and then subsequent to that, it can go and get obstructed at any part in the intestine. So the most common location where the obstruction occurs is actually the ileocecal valve, because that is the narrowest portion of the intestine distal to the second part of the duodenum. So that's the Mirizi syndrome. Then we have wall involvement, which may be in turn be inflammatory and neoplastic. And finally, we have luminal causes, and luminal causes are not something that I routinely I'm interested in, because it's always a foreign body. Now, inflammatory and neoplastic pathology can be, it differs based on which part of the gastrointestinal tract is affected, because Obviously, the cellular biology of the different locations of the gastrointestinal tract are different. So, inflammatory pathology that occurs absolutely anywhere is obviously inflammatory bowel disease, uh, and specifically Crohn's disease in that. Then there is eosinophilic enteritis, although eosinophilic enteritis is far more common in the esophagus, gastric tract, the stomach, and then in the duodenum. Now, neoplastic pathology that can affect any part of the gastrointestinal tract is actually a lymphoma. And then we have our gastric outlet obstruction, which can happen due to peptic ulcer disease. And you would recall that we will be discussing peptic ulcer disease as a separate topic under an approach to poorly localized but significant abdominal pain. So we'll leave it at that for now. Then we have gastric carcinoma as a neoplastic etiology causing gastric outlet obstruction. Then we have duodenal obstruction due to either a pancreatic pseudocyst or a pancreatic pseudotumor. That would be IgG4 related, although usually IgG4 related lesions are not this large. So it's usually almost always a pseudocyst. Neoplastic would be pancreatic carcinoma. Also, it would be a distal CBD carcinoma, although they're much rarer, and much rarer as compared to this would be a primary ampullary duodenal carcinoma. Now, in the jejunum, something known as immunoproliferative small intestinal disease, which is actually a heavy chain disease, that is alpha heavy chain disease or Seligman's disease, most commonly affects the jejunum, and you know, it's a lymphoproliferative disorder that is both inflammatory and neoplastic. So we'll get into that in hematology at a later date. But it can it would be technically then therefore both an inflammatory and a neoplastic lesion. Then we have small intestinal carcinoma, rare lesion, but obviously it only affects the small intestine. And we have mycobacterial infections, most commonly obviously tuberculosis, that can affect the ileum, ileocecal valve, and the colon, but most commonly affects the ileocecal valve. And finally, in the colon, we can have colonic carcinoma. Colonic carcinoma obviously has got a apple core lesion and a napkin-like constricting lesion, usually more common on the left side of the descending colon. So uh, that kind of lesion can result in obstruction. Okay. Now we have intestinal pseudo obstruction. So pseudo obstruction means there's no mechanical obstruction per se. So when there's no mechanical obstruction per se, we need to understand why exactly is there an obstruction. Why is the intestine not being able to peristalse properly, and why is it not being able to push the luminal contents? So this is the lumen of the intestinal tract, and along with that, lining the lumen is the mucosa. Just outside the mucosa, we have the muscularis, and this would be the lamina propria. Okay. What I'm going to do is I'm going to take a section of the lamina propria and the muscularis, and I'm going to enlarge it in the next slide. So in this slide, as you can see, I'm going to enlarge it. Now, in this slide, we can clearly, I'll show you the different parts of the muscularis propria and see what's happening. So within the muscularis propria, we have two smooth muscles here. The smooth muscles are connected to each other via some tight junctions that allow for continuous iron flow from one cell to the other. Then there are some voltage gated calcium channels located on this smooth muscle. So any depolarization of this smooth muscle would result in calcium entry into this smooth muscle, resulting in increased cytoplasmic calcium here, which would go into this smooth muscle and cause increased cytoplasmic calcium here, causing in both cases to the smooth muscle to contract. Okay, so that's how the smooth muscles of the gastrointestinal tract contract. So say you have hypokalemia. Now, hypokalemia has a very interesting effect on the resting membrane potential. It causes hyperpolarization of the resting membrane potential. The details of this we'll be discussing in our discussion on arrhythmia. But suffice to say, basically, at when when there is the cell membrane is in the resting membrane potential state, the only ion to which the membrane is not permeable is essentially potassium. Okay, so or sorry, the only ion to which the membrane is permeable is potassium. So the gradient of potassium on either side is what determines the resting membrane potential. So anyway, the when you develop an increased potassium concentration or decreased potassium counter concentration extracellularly, at that point of time the resting membrane potential becomes hyperpolarized. That means it becomes more negative. Okay, so now if the threshold potential is here normally, and the depolarization occurs like this, once the threshold the sorry, once the resting membrane potential goes down, okay, it comes down like this. Now the threshold potential is much farther away from the baseline resting membrane potential, so it is much more difficult for the muscle to contract. So as a result of that, the muscles within the gastrointestinal tract essentially are not no longer have the same amount of muscular tone. So that is how hypokalemia causes this. So hypokalemia makes the resting membrane potential more hyperpolarized. This causes the gap between the resting membrane potential and the threshold potential to increase, and that is why we end up developing the problems that we develop. Okay, so the baseline smooth muscle tone decreases. Now, on the other hand, hypothyroidism causes a decrease in gastrointestinal smooth muscle contractility by multiple mechanisms. So, the first mechanism is that it decreases the basal metabolic rate, and obviously, metabolism is required for ATP production, so the ATP concentration decreases, and ATP is required for relaxation of smooth muscle also. Altered composition of it changes the extracellular matrix composition in the muscularis of the gastrointestinal tract, resulting in decreased mechanical coupling between the smooth muscle and the extracellular matrix. And finally, it causes mesenteric hyperperfusion by causing or precipitating heart failure, or subclinical in this situation, heart failure. So these are the three by mechanisms by which hypothyroidism can result in intestinal hyperperfusion. And finally, we have hypercalcemia. So hypercalcemia actually results in the release of neuroendocrine mediators from the epithelial lining of the mucosa. One important neuroendocrine mediator in this vein is actually somatostatin, which is released by D cells within the duodenal mucosal lining. And somatostatin receptor 3 and 5 are located on these smooth muscles and basically inhibit contraction of these muscles. Okay, so that is one mechanism by which hypercalcemia causes decreased gastrointestinal motility. Secondarily, hypercalcemia also causes dehydration because it is lost in urine. It takes water along with it, and that would indirectly decrease mesenteric blood flow. Thirdly, there are direct effects of calcium of your hypercalcemia on voltage gated sodium channels, which we'll get to in detail in cardiology, but those indirectly result in a decreased temporal summation of the currents through these voltage gated sodium channels, and that causes a decreased tone. Now, you would have noticed these yellow cells here. These are actually the mesenteric plexus cells, and as you can see, they activate each other subsequently and release acetylcholine, which causes, which causes contraction of the muscle there. Now, importantly, uh, these cells are in turn under the effect of the parasympathetic nervous system and the sympathetic nervous system. The parasympathetic nervous system activates them and therefore causes or increased gastrointestinal motility and decreased sphincter tone, whereas the sympathetic nervous system increases sphincter tone but decreases gastrointestinal motility. So, if we have any cause of increase in the sympathetic activity or the sympathetic tone, that would result in decreased gastrointestinal motility. Or if we have any systemic pathology that is causing decreased parasympathetic tone, that would cause decrease in in intestinal motility. Now, so these conditions obviously naturally will result in decreased motility. Now, pain in turn causes a similar effect by increasing sympathetic tone, but it also activates intrinsic inhibitory reflexes, which is the reflex circuits within the mesenteric plexus, and this is one of the reasons why, in addition to causing wall thickening, pancreatitis can cause intestinal pseudo obstruction temporarily. Now, the causes of decreased intestinal motility due to an altered neural input can be or due to an abnormal response of the gastrointestinal tract to the normal neural input can be as follows. So, one is we could have, like I said, central nervous system disorders. like multiple sclerosis, neurodegenerative disorders, and myelopathy, where the neural input into the gastrointestinal tract is decreased. So the parasympathetic tone falls out of proportion to sympathetic tone. And obviously, this could happen particularly with multiple system atrophy (MSA). Uh, then we could also have disorders in which the neural input into the gastrointestinal tract is normal. That is, the amount of parasympathetic tone coming is normal, but the muscle itself is either fibrosed or dysfunctional. So if the muscle is fibrosed, that would be systemic sclerosis, and if the muscle is dysfunctional, that would be any type of myopathy. Okay, so these types of systemic disorders also result in pseudo obstruction. But as you would notice, I have shaded out systemic sclerosis because it's not a cause of acute intestinal pseudo obstruction, it's a cause of chronic intestinal pseudo obstruction. So, in fact, all of these disorders cause chronic intestinal pseudo obstruction, particularly systemic sclerosis, and should not be, considered as primary attributing factors for this. Okay. So that brings us to the end of this screencast. In this discussion, I have compared and contrasted between the three types of intestinal hypermotility syndromes, namely acute mesenteric ischemia, true intestinal obstruction, and intestinal pseudo obstruction. I have helped you deduce the causes of acute mesenteric ischemia, and I have notably also made you aware of the base rates of each cause. So non-occlusive ischemia is far less common than occlusive, and among the causes of occlusive, thrombotic is far the by quite a distance the most common cause, and vasculitis therefore is a uncommon cause. Okay. Then we've deduced the causes of true intestinal obstruction with an emphasis on non-surgical causes, that is those inflammatory causes. And we have deduced the causes of intestinal pseudo obstruction. We've understood how hypokalemia, hypothyroidism, and hypercalcemia, in addition to altered neural input into the gastrointestinal tract, that is in decrease in parasympathetic tone or an increase in sympathetic tone, um, or neurodegenerative disorders resulting in decreased parasympathetic tone, or decreased gastrointestinal wall responses result in decreased intestinal motility. And that brings us to the end of this relatively short discussion. I hope it's been fruitful. These are disorders that are clinically very important to differentiate from one another. However, are rarely discussed together. So I hope this has been helpful, and I'll see you in the next discussion where we'll be going into the role of imaging in helping us differentiate these three pathologies from one another. Thank you, and I'll see you then.